welcome to Health Alert. I'm Pam Butler. Today we're going to talk about pediatric orthopedic conditions, and joining me is Dr. Mark Willits. He's a pediatric orthopedic surgeon at Children's Hospital at St. Francis Health System. Welcome, Doctor.
Thank you.
Now, I want to start with you by asking about sort of pediatric orthopedic conditions in general. You were here before for another show, but for people that may not have watched that, just give us an idea. Are they really that sort of, are there a lot? I mean, you are an orthopedic, of course, pediatric surgeon, but when we look at some of the other issues compared to heart conditions for children and things like that, are there a lot of really orthopedic conditions that are about the same over the years, increasing due to certain kinds of birth defects or injuries or things like that?
Overall, pediatric orthopedic conditions have stayed pretty stable over the years, but they are a lot more common than what people would think. Hip problems are in about 1 in every 1,000 live births. Clubfoot anomalies are in about 1 in every 750 live births. So it's, and then you have, of course, scoliosis and other conditions. So they're much more common than what people think that they might be, but the expression, I call it, of those conditions in kids is very different. It can be very mild to very severe. So you may have children who have very mild conditions that go undiagnosed for years or maybe their entire life until they're 35, and they're like, I'm having this ankle pain and I've never really injured it, but and then they find out later in life that they had a mild foot condition that didn't really become symptomatic until all the wear and tear over a few decades. So
how about that? Wow. Well, wow. Let me focus on clubfoot, because you did just mention that. I know previously we did a show on scoliosis, and we might highlight that. We'll just see how we do. But clubfoot, what exactly is clubfoot?
Okay. Clubfoot is normally what we call an idiopathic condition where we don't really know why it happens, but somewhere along the lines of the development of the lower leg and foot region, during those processes, the foot gets caught in a stage of development so that it doesn't rotate to its normal position before birth. So the child is born with a foot with basically 4 different deformities. The back part of the foot is turned in, or what we call varus. The arch of the foot is a very high arch, what we call cavus. The front part of the foot is turned in, which is what we call adductus, the front part of the foot and the toes. And then from the ankle joint, the foot is stuck down in plantar flexion, or what we call equinus. So those 4 things are combined to place the foot into a position where it's turned up and in on the lower leg. So if you look at a picture of a club foot, it looks like a 9-iron in golf, is what it looks like. It's turned up, has a very deep arch. So there's a combination of deformities in the foot, not only to the soft tissues, the muscles and ligaments and tendons, but there's also changes in the structure of the foot as far as the cartilage anlage that will eventually become bone in children. So it's a combination of deformities.
Now with this deformity, and we'll talk about sort of how do you fix it and what does it do if you don't fix it, but is it difference in severity of it? I mean, what you described in terms of how it looks, can it be a little less turned in? And I mean, can you have it where it's not quite as pronounced, or does it tend to always look the same?
It will have a tendency to carry a general appearance, but the severity of it is much different from child to child. We can actually grade the severity of the clubfoot on examination by looking at how flexible the deformity is. Some club feet we call more postural, meaning they're very flexible, and when we examine the child in clinic, you can almost take the foot and put it into a normal position just by manipulation of it on exam. Other children who have club feet that are not idiopathic, they are more syndromic. Kids with spina bifida, kids with cerebral palsy, kids with various other dwarfisms and things can have very severe rigid clubfoot deformity that is extremely difficult to deal with. And a lot of that severity and grade is based on examination.
Okay, now, of course this is obvious then upon birth. It's not one of those ones we're going to figure out when we're 35, right?
Right, right.
It's upon birth. What do you do to fix it? I mean, is it fixable?
It is fixable. There's a certain, depending on the rigidity of the foot and the flexibility of it, most clubfoot is corrected by cast manipulation. There's a technique that was developed by Dr. Ponsetti and has been tested and researched, where the child goes through weekly cast changes to correct the foot deformities in a particular order, so that we can stretch the ligaments and tendons and also cause remodeling of the cartilage anilage of the foot, so that the foot will change positions and hold position. So families will go through weekly changes in the clinic with repositioning of the foot. At about 5 or 6 weeks into the casting, we usually have to do a minor procedure to release a tendon in the back of the heel so that the foot can come up into a more normal position. They get held in a final cast for several weeks at that point. And then once they come out, they actually go into braces that the child wears full time while they're an infant up till about the time they're going to walk.
Okay.
So, and then if they hold position and don't have recurrence, once they get to walking age, they come out of the braces. The weight bearing on the feet allows them to maintain correction, but they still wear braces at night until they're about 3 or 4 years of age.
Okay. Now, after that point of 3 and 4, is there any likelihood that this would still regress, or is it pretty much a done deal? The correction is going to be maintained and there's nothing else needed?
No.
How did I figure that out?
Yeah. Like anything, there's never say never in medicine.
Right.
So these are kids that we watch up until they're into their teens and their early adulthood. There are little things that come up as a child grows. Their bones grow, they get taller, their feet get bigger, their ligaments and tendons and muscles change. So we have to continually watch them on just very nice scheduled appointments to see if there's any recurrent problems. And as they grow, little things may develop in certain areas of the foot that need minor surgical operations to maybe major surgical operations to correct certain parts of the deformity that may be recurring. But the overall development of that casting technique by Dr. Ponsetti has really revolutionized the treatment of clubfoot, going away from the huge surgeries that used to be done on every child who is born. Now a large part of the deformity and a large part of these kids can be treated non-operatively, and maybe later in life very minor procedures that may need to be done instead of major corrective surgery.
Okay, now I've got a couple questions here. Then as the child is progressing, are there, you talked about the casting and the bracing and then watching and that, are there certain shoe restrictions? I mean, I'm thinking especially of, I'm not being stereotypical, but for girls,
Yeah.
you know, when you're wanting to, as you're growing into adolescent, you may want to do more of the flip-flops or the little heels or things like that. Are there certain limitations that should occur?
Normally I don't limit them in their shoe wear as they start growing. The main thing is that when they're younger, they've stayed compliant with the bracing. As they begin to grow and get older, I let them do all their normal activities. I don't put any restrictions on them. I let them live their lives. And if they begin to have a minor recurrence of the deformity in part of the foot or in all of it, then we just have to deal with it at that time. But I don't like putting restrictions on these kids. They have enough. There is a psychological burden on these kids because they know their feet are different, and so I let them be as normal as they can possibly be, and let them compete in everything they want to do, and not put restrictions on them to allow them to live normal lives. So. Okay,
well, we're going to take a really quick break, and I have a couple more questions about the clubfoot, and then we're going to switch into spina bifida. Okay? Please stay with us. We'll be right back.
Learning how to kick flip 6 stairs takes determination. So will getting into college. I've got what it takes. So do you.
Welcome back to continue our discussion talking about pediatric orthopedic conditions. Joining me again is Dr. Mark Willits. He's a pediatric orthopedic surgeon. here at Children's Hospital at St. Francis Health Systems. Let's jump in here now. Clubfoot, couple more questions. I mentioned about the girls as they grow into adolescence and any restrictions, especially with the different kinds of shoes and things like that. And you said absolutely not, but you follow them and see what changes may occur. What about for the boys, especially with really contact sports like, you know, playing football? I mean, girls play soccer too, of course, but football or things like that, are there any restrictions for them?
No, I don't restrict them in their activities and their sports when it comes to male participation either. There are no studies, there isn't any research out there showing that it's detrimental. Actually, the more active that you can be on the foot, maintaining weight bearing on it, it helps maintain correction and position. So the more they wear regular shoes and participate in activities, the better it is really for their overall deformity in their foot and to maintain correction. So
now let me ask another question, and then I have one more after that, promise. Once the correction has occurred, in terms of, you know, kids are very sensitive to how they walk, you know, and sometimes kids will point little changes out to other kids, and sometimes in not very kind ways. Once this correction occurs, is the child's gait going to be pretty normal? I mean, or is it going to be kind of off in terms of their balance or how they're walking, or tell me about that.
It depends on how much residual deformity they may have in their foot. The more normal position the foot is, the more normal the gait is. They don't limp or they may not walk funny, but some kids with some more greater amount of residual deformity of their foot will sometimes be a little self-conscious to wear things, you know, not wear regular shoes, wear flip-flops or sandals or something that may show residual deformity. The most common thing is for them to look in-toed because of curvature in the foot. Instead of being a nice straight foot on the outside and looking normal arch, their foot will be turned in the front part of the foot, and the foot will look a little bit bean-shaped, is what I say. Sometimes we have to deal with that residual deformity through surgical intervention to straighten the front part of the foot and give them a more normal-looking foot so that they're not so self-conscious. So.
Okay. Now, does physical therapy, because we think of physical therapy for a lot of things, does physical therapy help in terms of if there are some gait difficulties in terms of helping teach the child how to walk or strengthen it? I mean, does that help?
It can in certain situations. The one thing we know about clubfoot is that the muscles in the lower part of the leg, especially in the calf regions, are not normal. Okay. And what you see in children who have clubfoot on one side compared to the other is on examination you'll see that the girth or circumference of that leg is smaller, and that in even some cases it's maybe slightly shorter by a centimeter or so than the other side, and the foot may be even smaller by a shoe size or so. So sometimes the kids who have just one-sided deformity are a little more self-conscious because there is a difference in appearance between one side and the other that some kids and people around them can recognize.
Okay. So any therapies that can help are good things. Excuse me. Okay, you talked about the deformity in one. That was my other question before we swing into spina bifida. Can you have deformities in both? And if so, how typical is that, or is that unusual?
No, it's not unusual actually at all. Bilaterality and the foot deformity is very common actually. And it's actually a little bit more difficult to treat. It's like most conditions, the more involvement there is in the body, the higher the grade of the deformity. So the numbers on correction through casting are not quite as good as treating one-sided or unilateral deformity, but the numbers are still very good with cast treatment. And if you can't achieve all the correction in the foot, you can at least correct parts of the deformity through casting and more minimally invasive and conservative management, and then do specific procedures on areas of the foot to get the rest of your correction instead of having to do a major clubfoot operation.
Okay. Yeah. And I'm thinking about twins carrying multiple births. So this really is the last question before we go to spina bifida. But multiple births, do you tend to see more clubfoot in multiple births? Sometimes we'll think just there's less space in there for things to, kind of spread out.
There are some thought processes that crowding in utero may cause some malformations, maybe cause increased incidence of clubfoot. If it is, it's very minimal. I think the one thing that might be more shocking is that even though you may have like identical twins, you'll have one twin born with clubfoot and the other one not.
Wow.
And I actually have several cases of that right now that I'm taking care of here, where one twin has clubfoot and one twin does not. And so even though we may think we're completely identical, we're not completely identical. Right.
How
Yeah,
about
even
that?
those, yeah.
Now, I promise this is the last question. Because, excuse me, you mentioned about the identical twins and that. If you have clubfoot yourself, the person, and you said there is the idiopathic, we don't really know why, but do you see a greater incidence of the children that person will have later having a predisposition or possibility of developing clubfoot?
Yes. Yeah, there are, anytime you have a family history of a condition, whether it be clubfoot or spina bifida or other anomalies, the incidence increases. The family history is very important. And so the incidence in it does run in families. You'll have a child come in, and the first thing the mother says is, my brothers had it, my mother had it, or my father had, my granddad had it.
Wow.
And they remember going through the treatments to try to help correct and going through surgery. So it does run in families and has a tendency to not really skip generations as much as some other conditions. It seems like you'll find a child in the family pretty much every generation who has the condition.
Okay, I might as well finish this segment out with and just say the next segment we're going to do spina bifida, because I've got a couple more questions, Doc. One is that with do you see it more in certain cultures or races? Do you find spina bifida clubfoot tends to run that way or not? It's just pretty much across the board.
Yeah, we haven't found a huge difference in ethnicity and running through cultures. It appears to be fairly prevalent, or the same prevalence pretty much through any ethnicity. And the ability to treat really appears to be of no difference. We still do the Ponseti casting techniques and the minimal surgical operations if needed. So.
Okay, and the other thing I thought of is, because we have these environmental issues, where we always say how certain things are more affected by environments. Do you find that persons living in certain kinds of environments, maybe where there's higher industrial areas, they may be more likely to have a child with clubfoot? Does it have any relationship that way, or you found no environmental connections?
Not that we know of. We haven't had any research to date that shows us that if you're living in the Northeast compared to living in the Southwest, and different climates and different sizes of cities and pollution and environmental impacts, that it causes a difference.
Okay. Well, we're going to take a quick break, and I promise when we come back, we're going to start talking about spina bifida. Please stay with us. We'll be right back.
Separate raw meats from other foods by using different cutting boards. 3,000 Americans will die from food poisoning this year. Keep your family safer. Check your steps at foodsafety.gov.
RBIs and 36 homers. Swings at the first pitch and fouls it deep back into the stands.
Chill raw and prepared foods promptly. 1 in 6 Americans will get sick from food poisoning this year. Check your steps at foodsafety.gov.
Welcome back. To complete our discussion talking about pediatric orthopedic conditions, joining me again is Dr. Mark Willits. He's a pediatric orthopedic surgeon with Children's Hospital at St. Francis Health System. Let's jump in. Now, as promised, no clubfoot. We're going to move to spina bifida. Tell us, what is spina bifida?
Spina bifida is a condition that develops in utero, usually between the 4th and 8th week of the pregnancy when the neurological system is developing. That's a very critical time in the development of the child because you basically have a formation of the spinal canal and the spinal cord itself that begins to take place. and that follows a very standard pattern of closure of some structures in that development. What happens is that you have an interruption in the closure of the spinal canal and the elements of the spinal cord development, and the child gets left with a defect in the spine in the back, where the back elements of the spine and the bone don't form properly, and the spinal cord doesn't close and form properly. So depending on what level that is, whether it's higher up in the spine in what we call the thoracic region or rib cage area, all the way down to your tailbone or in the sacral region, that determines the severity of the condition in the child and what the prognosis is and what complications they'll have from it.
Okay, now with spina bifida, let me ask this. Is this a common sort of birth defect? I guess we'd list it as a birth defect. Is it very common? Is it not that, is it most rare? I mean,
it's not extremely common. It's nowhere near the incidence of, like a club foot or developmental hip. Yeah, it's less common, but we have linked research to show that it can be nutrition and environment. The biggest thing we know is that there's an increase of spinal defects like spina bifida with lack of like folic acid intake, and so it's actually recommended in mothers who are looking to get pregnant, who are planning on to start taking extra folic acid, because we know that decreases the incidence of what we call dysraphisms of the spine, such as spina bifida and other conditions.
Okay.
So,
and you were talking about too the general nutritional status of the mother during pregnancy or prior to also.
It's more prior to.
Prior to,
Yeah,
okay.
once you get into the pregnancy, the neurological system is the first to begin to develop.
Okay.
So one of the first, along with other systems developing at the same time, but it's really that preparation, that pre-pregnancy, taking the folic acid, having your nutritional status be good, that can eliminate or decrease, not totally eliminate, but decrease the prevalence or incidence that you may have a child with spina bifida. And of course, family history, having had a child with spina bifida previously, are all risk factors, and things such as genetic counseling and stuff needs to be done in families or in couples that have had a child with spina bifida or other conditions, to know what the incidence is of having another child with that condition, or what can be done to decrease the risk if they have more children.
Okay.
So
now, with spina bifida, since it is in utero, can this be picked up on an ultrasound? Is this something that the parents can know prior to the birth of the child?
Yeah, and it can be picked up on ultrasound. It can also be picked up on an amniocentesis. There will be changes in levels in the fluid. They test for certain things. But we do have one or two centers in the United States who are doing experimental surgery, actually doing in utero operations to go in and actually close the defect while the child is still very young in utero, because they believe that will allow proper development as the cells have more potential to develop in different ways, and decrease the severity, if not hopefully maybe eliminate having spina bifida when the child is born. So that's something that's kind of on the edge out there and trying to be developed, and we don't have really any numbers yet on long term how those few operations are doing.
Now, once the child then is born, what happens? What do you do, and what's the procedure?
All right, when the children that are born with what we call spina bifida, it's called myelomeningocele is what we call it in my world.
Okay.
Neurosurgery has to jump in very quickly. Their job is to come in and actually close down the deformity, because you basically have an open spinal canal to the air with a sac, basically with fluid. So they have to close that down, get a coverage on it so that you keep the child from developing meningitis and other complications. So depending on the level of involvement of the spine, that determines their course. A lot of kids wind up needing shunts going from the ventricles in the brain down to their abdomen to take off excess fluid, because they can develop what we call hydrocephalus, or enlargement of fluid collection in their brain, which can cause neurological deterioration. And then you have to start looking for their orthopedic conditions. the higher the level of involvement up in the spine, then the more affected nerves there are below.
Okay.
And so the child develops muscle imbalances in the feet and legs and even into the spine that cause deformities. So these are children who they develop severe club feet.
Okay.
They develop severe knee contractures and hip contractions, even dislocated hips because of muscle imbalances that are extremely difficult to treat. And then, of course, they can develop very severe spinal anomalies and deformities that are very hard and very difficult to deal with. So
Okay.
it's a very multidisciplinary approach to spina bifida. At the Children's Hospital at St. Francis, we have a spina bifida clinic.
Okay.
Where once every couple of months there's a morning where children come in with spina bifida. There will be neurosurgery and family practice and physical therapy and OT. Everybody following these children to make sure that they have all the needs that they've had. Until recently, the children for orthopedic needs have had to travel out of town to Shreveport, to the Shrine, or
Right,
somewhere.
right.
But now, since I'm here now and have arrived in the first part of August, I'm beginning to take on those children with spina bifida with those orthopedic conditions that need to be treated.
Now, excellent. Now, with the kids in our last few minutes here, is their life expectancy any different because of spina bifida and all of the accompanying needs that they have depending on the severity, or do they tend to live a normal life expectancy, lifespan?
The life expectancy years ago used to be much shorter, just because our medical care wasn't as good as it is today, and with the advent of newer medical technology, medications, treatment, just learning really over the years and research and looking at treating these patients, we have discovered what is the best kind of evidence-based medicine approach and looking at the research and how to treat these kids. So the life expectancy in a child with a low-level spina bifida is basically normal.
Okay.
Children with higher levels of spina bifida, the life expectancy is still into the 40s, 50s, but not fully out because they run into more complications through their life health-wise to deal with, yeah.
Okay, well, I'm going to have you back because I wanted to try to get in cerebral palsy, the hip conditions, and all of those things, and of course you knew I wouldn't make it. So I'll have to have you back. Thank you so very much.
I appreciate it. Thank you.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear questions, comments, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/healthalertusa. And remember, talk with your physician, get pre-pregnancy counseling, get your health in order so that you can have the healthiest baby possible. And then if something happens that's unexpected, stay in close contact with your doctor and do all you can because you both deserve the best. Take care.